Hi, I'm Amy, and today I would like to bring to you empowering longitudinal electronic health records to uncover real-world evidence in chronic disease. So the goal today is to actually introduce you a pipeline for leveraging longitudinal electronic health records for real-world evidence. But before we go in any further, we have to make sure that we're all on the same page of what exactly is real-world evidence. So before this term actually comes into play, a lot of the clinical decisions were actually made based on traditional randomized clinical trials. So here's like a timeline illustration of what a traditional study would look like. So first, you would require a quite time-consuming recruitment stage, and usually only a limited number of patients will be recruited into the study. And then you would have like a pre-designed fixed follow-up duration period. And at the end, you would summarize the results, analyze, and report them. But in monitoring chronic diseases and disease-modifying therapies, you would need not only short-term, but also longer-term efficacy outcomes. For instance, like disease activities or like disability status change. And also for some outcomes with extremely low case rate, for instance, the serious adverse events, you would actually require a much, much larger patient population in order to arrive at any conclusive results. So with that, the FDA actually created a framework for the real-world evidence in response to the 21st Century Cure Act. And their framework has been continuously updated. It's updated as of 2023. So the document is called Considerations for the Use of Real-World Data and Real-World Evidence to Support Regulatory Decision-Making for Drug and Biological Products. Right, so exactly how does FDA define this concept of real-world data and real-world evidence? So real-world data are data relating to patient health status and the delivery of healthcare routinely collected from a variety of sources. So one of the most important sources of real-world data actually comes from the electronic health records, which we will also explain in a bit. And the real-world evidence is the clinical evidence about the usage and the potential benefits or risk of medical products derived from the analysis of real-world data. So now we return to the concept of electronic health records. First, I would really like you to know that we actually have a large amount of electronic health records. So here you could see a map of US. So in this map, we show you the percentage of hospitals that have adopted a certified EHR system in different regions, right? So you can see on average, US have about 96% of hospitals that have already adopted a certified EHR system. So you would have a very representative population across geography. And not only that, the electronic health records also includes a variety of data formats. It includes structured forms and also clinical notes. And if you do some lab tests, then you would record your lab values as well as your biomarkers. And if you do a CT scan or MRI scan, then you will record your medical images. So it includes a rich amount of clinical information. And it is also longitudinal, meaning that it will record all visits of a patient. But despite all the benefits of the EHR having a very representative population, very rich clinical information that are usually longitudinal, it does have the caveat that it does not have readily usable data. What I mean by that is that they're sometimes stored in quite a messy format or different formats, and there will be I would say a large amount of missingness in terms of, for instance, if you're looking at a specific outcome of interest, and it will also include many noisy data. So, as a concrete example, if you're interested in cancer recurrence as your outcome, then you will know that there is actually no diagnostic code directly for recurrence. And if you refer to the clinical notes, you will see that the term recurrence in the notes does not consistently indicate recurrence. So it could sometimes even refer to like a historical recurrence, but not exactly at the present time. And usually in the EHR, unlike the registry, it does not have a very regular follow-up. So these are the challenges for directly applying EHRs for real-world evidence studies. So that's why we will present now a pipeline for mining the EHR for real-world evidence. So I will give you like a conceptual summary of how exactly that we think that we could do that. So on a very conceptual level, what we're trying to do is say we already have some well-documented outcome of interest that are collected from the registry. What we're trying to do here is to say, okay, so I have a large amount of EHR data stored in the routine care. Could I use these could I try to learn some indicative patterns inside the EHR to help me to come up with a good surrogate for the true outcome of interest? So to do that, you could try to leverage different types of models, including like machine learning models. And one important step that you have to remember is that you need to validate that your algorithm is actually good enough. So in order to do that, you do have to set aside like a small amount of gold standard labels just for the sake of validation. And once you have these surrogate outcomes or these pseudo outcomes, then you could further use them as the real world evidence outcomes for any downstream clinical studies that you're interested in. Right, so our pipeline includes two major parts. One is how you do data curation, and one is we try to introduce you a longitudinal phenotyping algorithm called LATTE, and then we'll further illustrate using a case studies of renal cell carcinoma recurrence prediction. So the first steps that you have to do is in collecting your data is to standardize them. Because as I've mentioned, there are different formats of the data. For instance, you have the clinical notes. So for the clinical notes, you could try to turn them into like a list of clinical terms so that you could count them. Just like the codified data, like the ICD code and such. And the second step is that you could try to roll up the local codes from multiple institutions into a more standardized format according to a known hierarchy. So I will provide a more detailed example to help you understand that. So for instance, this is like a mock clinical notes. So there are, in fact, a varieties of natural language processing tools that could actually help you identify the entities, or more specifically, the clinical terms inside this clinical notes. For instance, if you take a look at here, so you will see that the concepts include colorectal cancer and biopsy proven, etc. And some more advanced NLP tools could also identify like whether this concept exists in affirmation or in negation, right? For instance, these two concepts were actually does exist, so they have like positive existence, but then here it says no evidence for metastasis disease. So this metastasis disease itself is actually a negative mention. So you could try to identify those, and then you could turn them into like a list of counts. So basically, you can count the 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 number of appearance of the clinical concept. And so in doing that, you actually turn them in sort of in a similar format to your ICD code or those standard codes. And in terms of rolling up the local codes, right? So you will know that in different institutions, they usually have different ways to code their labs or procedures, etc. But in order that you could do like a study on a larger scale, probably also across institutions, it would be really beneficial if you could roll them all up to a very standardized format. For instance, here I will illustrate how do you roll up local codes, group codes to first ICD codes, and then you can further roll them up to the fee code, which comes from the FEWA's catalog. So if you're interested, we also have different kinds of hierarchies provided in this website below. So it also includes hierarchies, for instance, for medication and for procedures and whatnot. So you could do all of them, and you could standardize all of the codes into a very, very well formatted format. Right. So after you do data standardization, you will know that you actually do have like a very, very large amount of clinical features at your hand that you could use. But then you wanted to study a particular disease or a particular outcome of interest, right? So for that, you won't need everything. And in particularly, if you wanted to have a more computationally efficient algorithm, it would be actually very, very beneficial if you try to do a feature selection, or here I call it the variable selection first. So a tool for you to do that is actually what is called a knowledge graph. So we also have some examples down below that you could play with them if you're interested. But mainly what this knowledge graph does is, for instance, if my disease of interest is multiple sclerosis, then you put it in multiple sclerosis, and then that system would try to return a list of variables that were actually quite relevant to that disease that you're studying. For instance, for multiple sclerosis, you would have, for instance, a diagnosis for muscle spasticity, optoneurotics, or it would also include, for instance, medications for MS, like natalizumab, baclofen, and also fingolimod, etc. So with that, you could essentially filter out all the less relevant features and remain all the important features for your outcome of interest. And with that, you're actually ready to go one step further to say, okay, now can I try to construct a cohort for my study, right? And usually what people would do is say, okay, so because for different diseases, they usually come with a certain ICD code, for instance. So you could say, okay, how about I just take that diagnostic code and say, okay, if that patient has a diagnostic code for that particular disease, then I would say that patient has that disease. But as I have argued before, so usually in terms of the diagnostic code, it could also include a nodding noise. For instance, like the misdiagnosis and stuff like that. So what we will recommend is actually for you to train like an algorithm to do this phenotyping. Like for instance, you could take like the EHR features, including the diagnostic code itself, obviously, and then you could try to use an algorithm to help you to phenotype whether this patient has that disease or don't have the disease. And obviously, if you have a large amount of labels, meaning that for a subset of patient, you do know exactly via manual review or whatnot, you do know that they do have that disease. You could use a supervised method, but what we recommend is actually you could try to leverage a semi-supervised or an unsupervised method with some examples that I listed here, because these methods actually require a much less gold standard labels to train. But still, one important step is for you to do quality control on your algorithm. So in order to do that, you still need like a small subset of manually curated labels just to confirm that your algorithm is indeed perform as well as you expected. Right. So after the entire data curation and standardization stage, and as well as the cohort construction, now comes the interesting part, which is how do you do longitudinal phenotyping? So note here that usually our outcome of interest is actually uh, for like a chronic disease, like cancer recurrence as an example. Right. So usually that outcome stretches out on a long time frame. So you would need um so what longitudinal phenotyping means is that consider like a time frame of a particular patient, and he would usually have the EHR um, recorded for each of his visits to the hospitals. Uh, and what our longitudinal phenotyping algorithm tries to do is to learn some indicative patterns from this group of EHR features to come up with fitted algorithm to predict the outcome of interest. For instance, the probability of the recurrence event. Right. So here we actually wanted to introduce an algorithm called the label efficient incident phenotyping algorithm, or as we call it, LATTE. So this particular algorithm has actually been published in patents earlier this year. So I've also feel free to check out the paper. But what we wanted to highlight, three key advantages of this algorithm. First is that it's very label efficient via the construction of silver standard label. So I would get into a little bit of the concept of silver standard label in my next slide. And the second advantageous point of this algorithm is that it does include, or it can leverage, longitudinal information. And the third point is that it's relatively generalizable across different institutions. So here, just for clarity, I provide some definitions for some terms. So when we say features, we also mean like variables, and we actually refer to like the log counts of the EHR codified concepts, such as the ICD or the medication code, or like the narrative concepts from the clinical notes. And when I refer to like outcome or labels, I'm actually referring to the outcome of interest in the study. And so for the labels, there are two types. One type is the gold standard labels, which are actually the clinical variables that were defined by the clinical experts through manual chart review. And we also have a set of the silver standard labels, which are actually noisy proxies of the gold standard labels that can be computed and readily extracted for all patients. So here is a schema of the LATTE algorithm. So it requires a longitudinal input of the NLP as well as the codified features for all the patients. And then what's really cool is that it could then leverage um, a knowledge graph to weight the importance of the outcome of interest. Um, so suppose your outcome of interest is multiple sclerosis, right? And you have given it a list of EHR features as well as the narrative features, then we could leverage the knowledge graph to try to reweight the importance of each features. So by doing so, you actually upweight the features that were really relevant to your outcome of interest, MS, for instance, right? And then the second module is actually to do a patient period reweighting because a patient can revisit the hospitals due to different reasons. And what we are really only interested in the visits that were directly related to the outcome of interest. So you would downweight some of the visits that were actually irrelevant and upweight the visits that were actually relevant. And then we would do like a sequential modeling using a bidirectional GRU. So essentially, this is a well-known machine learning framework that could essentially leverage the longitudinal information across all the visits. And then at the end of the day, we would have a predictor module. So the predictor module actually contains two types of predictors. One is pertaining to the gold standard labels, and the others were actually using the silver standard labels. So if you only require the silver standard labels, then you can imagine that your training sample size can include much more patients. Because even for the patient without any gold standard labels at all, you could always compute their pseudo labels as the silver standard labels. Okay, so from the paper, it has actually validated the usefulness of latte. So we have three different outcomes of interest. One is type 2 diabetes onset, heart failure onset, and the third one is multiple sclerosis relapse. And we have compared, so the latte method is the curve in red, while the comparator groups were, so the comparison models were the other lines here. So from here, you could effectively see the x-axis represent the number of labels. So if you only have like a small number of gold standard labels, then actually latte can already perform incredibly well. So I think that is the key takeaway to say why latte is label efficient. And we also like validate that latte can perform well across sites, meaning that if I train, so meaning that it is good in terms of generalizability. So in order to test that out, we sort of trained on one institution or one cohort particularly, and then we try to transfer to the other cohorts. And so, for instance, here we are actually training on the MGBRA cohort to transfer to the biobank heart failure cohort as well as the VA MVP cohort. And from the AUC, you can already see comparison to the other model or the other methods. The latte algorithm will have like a good AUC on the in-domain test set, but you will also do relatively better than the other methods on the cross-institutional test set, right? So here we give you an example using the renal cell carcinoma risk prediction. So as we have also previously mentioned, so it is actually kind of a challenge to actually curate the outcome for cancer recurrence, because there's no diagnostic code and the recurrence terminus does not really consistently indicate recurrence, right? So that's why we sort of leverage Latte by inputting the monthly count of the selected EHR features. And what we're trying to do is that we're trying to derive a recurrence time from the longitudinal Latte prediction. So we find a threshold such as the derived recurrence rate matches the observed recurrence rate in the labeled data. And we derive the recurrence time as the first time the Latte score surpasses that particular threshold. Right, so this study was actually covered in this particular paper below and has been submitted to Annals of Oncology. Right, so first is like the construction of the study cohort, as we have previously mentioned. So we first extract the patients with the diagnostic code of RCC, but then we will further need to phenotype them to make sure that they actually have the RCC, not just due to misdiagnosis. So, so we would have 14,000 patients that were phenotyped as having RCC, and for these particular patients, we further subset them with into different categories according to, for instance, their tumor stages or their tumor grades. And so this is essentially how we leverage Latte in that particular case study. So one important thing is how do you train a silver standard labels, or how do you derive the silver standard labels? So what we did is that we leveraged a tool called the NICE tool. So NICE stands for like the NLP interpreter for cancer extraction. So what this tool does is that it could take the clinical notes and then extract the stage, the grade, and the nephrectomy information from that clinical notes. And then we sort of use that as a particular silver standard label. And obviously on the side, we do have some gold standard labels that were curated from chart review. And what we did is that we just input all the EHR features into Latte together with the silver standard labels as well as some of the gold standard labels to be used in the training of Latte. And then this particular algorithm will sort of return a longitudinal phenotyping of the recurrence. And for our validation, we do set aside some gold standard labels to do the validation. So one task is to phenotype whether a patient has ever had any recurrence. So it's a binary problem. It's like 0 being the patient never have a recurrence event throughout all the observed visits, and ever being, well, at least 1. And the second task is to exactly pinpoint the times of recurrence. Right, so this is like a longitudinally, you have to pinpoint which are the month. Like for each month, you have also a binary label of whether this month the patient has a recurrence event or not. So obviously, the second task is more challenging than the first task. And at 95% specificity, so these are the results for AUC sensitivity, PPV, and NPV. So, for instance, by referring to this AUC, you will see that the Latte algorithm actually achieved a 0.95 AUC on the ever-never task. And even though it does do slightly worse in like pinpointing the exact recurrence time, but it is still close to 0.9, which is quite impressive, I'll say. And then You could then use the trained latte algorithm to help you to do some sort of analysis. For instance, you could uh, here you could use the latte algorithm to return like accumulated uh, incident rate for different tumor stages and grades, right? So here, in the first column, the plots and the colors, the different lines actually refer to different tumor stages. For instance, the blue line referred to the T3 stage, the green line is the T2, and red is the T1. So as you can see here, so you will see like a consistent increase of the accumulated recurrence rate for the patient having a higher T stage, right? So you can also observe something similar in terms of the grades, right? So here you have 4 grades, like grades from 1 to 4, as indicated by red and green, blue, and purple. So you could see that and the patient will indeed have like a higher accumulative recurrence rate as their grade becomes larger, right? And particularly if you zoom into the T3 stage and then you arrange the curves by their particular grade, you also see like an elevated recurrence, accumulative recurrence rate. And actually you will see that regardless of the grades, they all are already pretty high, like in comparison to like the others. So in this table, you actually can observe the same findings. So the RFS refers to the recurrence-free survival. So you could actually observe the same patterns. So for instance, if you look at the different stage subgroups, you will notice that the recurrence-free survival actually drops as the stages become higher. So the same can be observed with the grade as well. Right. So in conclusion, we should briefly introduce you a pipeline for leveraging longitudinal electronic health records for real-world evidence. And we also provided a case studies to illustrate the effective modeling of the longitudinal EHR data to generate cancer recurrence outcome. And these EHR generated outcomes can be further applied to various downstream applications. For instance, it could be leveraged in doing causal modeling for observational studies. And actually, we do have like a tutorial paper plus like a GitHub under preparation for this particular pipeline, which also include some guidance with respect to how do you do like further causal modeling based on this EHR generated outcomes, and how do you do some steps of calibrations of that outcome. So yeah, so stay tuned for that upcoming tutorial, and that's all. Thank you so much.